Good afternoon and welcome. This webinar is part of the California Institute for Behavioral Health Solutions Continuum of Care Technical Assistance. The project is funded through a contract with the Department of Healthcare Services. Today's webinar is the third of a three-part series of webinars on trauma-informed care. Today's focus is trauma and specific issues for child welfare and provider self-care. Before we begin today's webinar, we have a polling question we'd like you to answer. This will help us get a better understanding of our audience today. So please tell us where you work. Are you working in state or county child welfare, state or county behavioral or mental health, a contract agency or a community-based organization providing services, probation, or other? So we'll pause while you participate in the poll. And we're going to close the poll in just another minute here. Okay, so we're closing the poll now, and we'll tell you what the response was. Kelly, can you tell us the response?
Yes, we had 22% in child welfare, state and county, 14% is behavioral health, state and county, 35% of the audience are CBO, contract agency providing services, 1% probation, and 28% other. So
great. Thank you so much for that. So let's move on with our slides here now. And we want to tell you about our presenter, who is Kristen Dempsey. Kristen is a senior associate with CIBHS and has over 20 years of clinical experience providing therapy for adults, children, youth, and families. She has participated in the Neurosequential Model of Therapeutics, or NMT, training with Dr. Bruce Perry at the Child Trauma Academy, and has also helped develop trauma-informed behavioral health systems of care. Kristen is currently completing research on supported education models to support foster youth college completion. In addition to her interest in trauma treatment, Kristen leads trainings in motivational interviewing, applied suicide intervention skills, and treatment of co-occurring disorders. I'm going to go ahead and turn the presentation over to Kristen Dempsey now.
Hello, thank you, Kim, and thank you, Kelly. Welcome, everyone. It's really wonderful to have you back if you're returning for another webinar, and welcome if you haven't been here before. I'm going to go ahead and just do a little review of trauma. I keep saying that every time, but of course this is what we're talking about. But today's webinar, we're going to just spend some time going back into the idea of what we're looking at diagnostically at times with trauma and some very basic interventions. We'll also get into some more specific issues or concerns that come up for people often working in child welfare settings, but certainly those of you working in behavioral health settings will notice this as well. So just some more trends around what we see with our youth who have had histories of trauma. And then we'll finish up today's meeting talking a bit about self-care for providers. So we're on our What is Trauma slide, and this slide is the slide that's been through all three of the webinars. We just keep it here as a place to make sure we're all on the same page. And again, I don't want to totally repeat everything I've said before, but just as a bit of a summary, thinking about trauma as events, series of events, or contexts in which an individual's and sometimes a community's ability to cope and to manage and to feel in control is really overwhelmed. There is that sense a lot of times of feeling out of control and helpless. These are all hallmark signs of trauma. And they're systemic in that it doesn't usually just impact one aspect of an individual, but it also can be physically, emotionally, spiritually, and cognitively harmful as well. So that's just a way of getting started to kind of frame our discussion about what is trauma, and also thinking, as I've said before, that trauma is really subjective. So people are impacted by trauma differently, and the amount of trauma one experiences and different types can also have a significant impact on what we see in terms of the people we work with. So we're going to go into another poll. We thank you in advance for the polls. It's really helpful as a place for us to think about where everyone is in their work. And I'm just curious, I was wondering, all of you out there, and knowing that many of you are working for community-based organizations, some of you are working with counties, also child welfare, and one in probation, and there's that 25%, I think, that's in other locations. So I have a feeling you're seeing young people with different aspects of trauma, and so we have on this poll depression, anxiety, PTSD, someone meets those diagnostic criteria, attention deficit hyperactivity disorder, that's the ADHD, and substance use disorders. You can check off the one that maybe you see the most often. If you had to guesstimate, you might actually have data. And we know that many of you are seeing combinations of all these as well. But just to see, what do we have in our community? And when I mean community in this case, I mean this specific webinar. And you can also type into the question box. If there's something I don't have listed, we can only list so many. And I'll give you a second to do that. Mm-hmm.
We're going to close it in about 10 seconds.
Okay.
All right. Close the poll.
So it looks like we see about, in terms of issues, we see, Kristen, about 63% have depression, 61% say anxiety, 55% post-traumatic stress disorder, 44% ADHD, and 47% a substance use disorder.
Okay. Thank you, Kim. So it's interesting that we see fairly close results among all of these larger categories, and then in our side box we have people saying they see also PTSD, ADHD, and substance abuse, depression, conduct disorder. I think one thing this poll is telling me, and it's actually what I'm going to talk about in a minute, is that it's challenging when someone has a history of trauma to have all their trauma symptoms and signs and concerns fit into specific diagnostic categories, and that often there's bleeding and blending, and that's how we often end up with folks coming in who may have a number of different diagnoses at any given time that we're seeing them. A lot of young people, quite young, tend to collect a number of different diagnoses, for instance. And so clearly anybody with a history of trauma could have any number of things that are listed in our diagnostic manuals, with these being some of the more common ones, because depression and anxiety themselves are components of PTSD, for instance. The thing to think about here, and that we're going to talk about at our next slide, is what's happening when some of these trauma, especially complex trauma, start to interact. So we're trying to really think about what's happening over time when people have not just one incident of trauma, but multiple incidences of trauma, and how's that showing up? How's it different for people in terms of their help-seeking behavior? How is that also showing up for youth of different cultures and from different backgrounds, maybe who weren't born here, in terms of how do they even talk or are able to share about their signs and symptoms? One thing to think about as well as we look at these diagnostic categories is thinking about what we were talking about couple weeks ago, last webinar, about externalizing versus internalizing behaviors. And so that'll show up in different types of diagnoses as well, right? Where some, we talk about being hypo-aroused or hyper-aroused, and we were reviewing how that's related to the fight, flight, freeze responses. So you may have people who are more internalizing, that is, a lot of the distress is internal, more depression, dissociation types of signs and symptoms. We may have more externalizing behaviors, youth who are more impulsive, acting out, conduct disorders, these various more aggressive or acting out types of behaviors that we see. And so if we look at this slide that we're looking at now, the legacy of trauma, what I attempted to do was look at some recent research and try to get an idea of what are we noticing about some of these interactions? What are we learning about with early trauma, what happens diagnostically? And so there's still a lot to be explored and discovered. Hodges is starting to look at, that's our first paragraph there, the first bullet, about the fact that different types of traumas to some extent have different types of impacts. We may, for instance, note that sexual traumas are often associated with later sexual fears. Sometimes we also see early onset psychosis connected with sexual trauma. Also, physical assaults or abuse may be connected to subsequent anger or aggression. That's probably not so surprising there. Psychological abuse may be especially associated with low self-esteem. We've seen neglect sometimes be connected to more antisocial types of behaviors. And then one thing that we do know is that we're getting, as we look at some people with these complex presentations, we're getting a greater number of different types of trauma exposures being associated with a whole wide array of psychological outcomes. And so we can have a combination of many of our diagnostic categories, which is at least partly why many of you had all these different components that you've been seeing in your work. If we look at our second paragraph there, another thing to consider is substance use disorders as well, and I talk about that a little bit later in this webinar. We talk about behavioral health, we're talking about mental health as well as alcohol and other drug disorders. And it is important, of course, for assessment, but we're thinking about this as, substance use being often an outcome as a way of coping, or certainly can also be an externalizing behavior. But another important piece that Wright Fagan and Pinchevsky also spoke to is the idea that when you start to use substances, there's another dynamic that occurs, which is the narrowing of their world and their support systems. So we have not just signs, symptoms, behaviors that we're managing, but also the community supports become more limited, or the environment itself becomes more toxic, really, when substance use becomes more prevalent. And then finally, if you look at our last paragraph, we have a piece here also about culturally among youth, we may have different expressions of post-traumatic stress. And there's young people who are noticed from diverse backgrounds where negative mood, more the depressive symptoms, anhedonia, interpersonal problems tend to be more the dominant signs of post-traumatic stress disorder than maybe some of the other signs or symptoms that one might be looking for. So just being thoughtful about somebody's history, and if we go to the next slide, kind of conclude with this thought around some of these ideas, which is, as I say, a young person might meet the diagnostic criteria for any number of behavioral health disorders, and there's so much potential for co-occurrence. So being open to the fact that when we have trauma histories, it's really important to be thinking about all the different pieces that might be in play in diagnostic presentations. And as I said last time, I'll repeat this time, it's so important to be able to use some aspect of an assessment tool, or to be asking about what happened to you. And as we do trauma assessments, and again, I don't want to repeat all the different types that are out there. You can always refer to the previous PowerPoints, but also be aware that trauma assessment can take some time. Even the first run of an assessment, you may have certain results, but as youth and families become more comfortable with us, as they actually remember more, as they may even stabilize or feel safer in the community or in the system that they're being seen in, it's likely that more trauma history might emerge. So being aware of the fact that trauma assessment, or really any assessment, but certainly a trauma assessment, should not be a one-time event. And so this idea, again, about what happened to somebody is so important in terms of a focus in addition, or maybe in connection to what's wrong with someone. So if you have someone, for instance, who maybe has all the signs and symptoms and meets the criteria for, let's say, attention deficit disorder, how might that impact your interventions, your treatment, if they had a trauma history versus if they don't have a trauma history. And this might be actually a great discussion to have amongst your staff and really be thinking about what do we do, if anything, different. And our next slide will address that a little bit as well, because what we're thinking about when we think about what happened to someone, we're always trying to figure out what's the function of this behavior or this symptom, because we don't necessarily frame symptoms as just being a problem. We try to figure out, well, what's the meaning for this particular person? How might this be something that's showing up as coping gone awry, so to speak? And so we'll get to the next slide here. I'm going to go into this a little more detail. I talked about this somewhat last time, and I want to go into some more examples, because this is such an important issue in terms of what are we seeing, and then how does this translate into how we're working with people. And so it really helps us if we're trying to devise a best treatment plan, best change plan, or intervention, is to consider their current coping. And as you see in that left-hand column, the coping does not mean that it's functional, at least not at this point. So many of us, if you think about our habits, we do them because at one point, maybe even currently, they did something for us. Even if we're having consequences down the line, at the time, there was something about it that might have been helpful. And so youth in particular don't have the necessarily insight or experience to always be able to reflect and analyze that what they're doing might not be terribly helpful. So if we have a trauma frame and we look at something like in this left-hand column, a young person who's triggered by a loud voice and throws a chair, and we can punish, but punishment isn't necessarily helpful. Discipline might be necessary. And ultimately what we want to do is be able to think about treating alternatives. So if someone was triggered by a loud voice, if I'm able to work with this youth to help them identify the trigger and then to practice self-soothing and self-regulation skills, we can hope that over time that's going to reduce the incidence of wanting to throw chairs, even if it takes some time, and even if they still need to have some natural consequence or discipline around throwing chairs, because we have to keep the community safe. Other examples I have here include youth who might be defiant, angry, does not want to participate. What we want to be thinking about kind of longer-term interventions is being able to help build relationships with people, so there's more of a connection and attachment and a responsibility and an interest in actually not exploding and wanting to engage in some ways, finding meaningful roles for young people. So they feel like they're useful, their time's being used well, helping them develop values. Sometimes we behave badly when we can't really connect to any reason not to behave badly. So what I'm trying to say here is if we have values and if we can explore those, like maybe we want to build community, to have relationships, to connect with others, even to have certain concrete rewards, it's always helpful to have a young person build those and be able to explore how any specific behavior, like yelling or being defiant, how is that helping or not helping us get to that value, that ultimate reward that they want to achieve. And as you all know, working with youth, we have to repeat these concepts and be very concrete about them over and over again. So it's a process of learning if they haven't learned some of this behavior and relearning over time. Here's what's more internalizing: depressed, cuts, attempt suicide. Again, we want to build relationships and engagement, attachment with others, have alternative, safe, and active behaviors. Like thing that originally comes to mind is like physical activities, sports, for example, but there might be other things they're interested in, youth groups, and identify and build supports via mentorship. So there can be more of a connection, more places for outlet, and to evoke some of those painful feelings with other people instead of resorting to self-harm. I'm going to go to another slide here for a second, and got some more ideas here. Here's another one that says potential, and let me make sure we got Okay, great. Someone refuses to socialize, aggressive towards others, and lacks interest in relationships. Sometimes we have youth whose trauma is such that they really don't relate well to people. Even trying to find a mentor or connecting with peers might just be very challenging. For a lot of those youth, animal-assisted therapy, horticultural therapy, these things that are other than connecting with people, connecting with animals or the environment first, can be a nice way of helping them become engaged, helping them connect to living things, so they can start to develop this sense of interaction, being able to care for themselves, care for others. It's wonderful living metaphors in animal and plant therapy. Sometimes we have young people who are easily stressed, cheerful outbursts, and practicing self-soothing, as we discussed last week. We had mindfulness exercises and focusing exercises. But a lot of times, rhythmic and repetitive behavior can be very soothing. Connecting with music, even having music in the background of what they do. Other safe and effective activities such as mindfulness. Even physical activities that allow for a certain amount of repetition and rhythmic movement like dance or other types of exercise can be very useful in that regard, in terms of helping to, again, regulate mood, helping someone get in touch with their body and be able to self-soothe when triggers occur. So part of what we're doing is we're really helping to find ways, based on where the youth is cognitively, emotionally, developmentally, finding ways for them to find alternate paths for coping. And again, this is not an exhaustive list. And just looking at these responses seems probably terribly oversimplistic indeed, because again, we have a lot of complexity. So what I'm really hoping to illustrate here is not that these are all the answers to all the problems that any young person can have, but really modeling the mindset that when I see a specific behavior coming from a young person, how might they be using that as a coping gone awry, so to speak, and how can I help them develop, based on what's happened to them, how can I help them develop awareness, reflection, and alternative responding? Go to the next slide here and show you some other helpful information. Another thing that we want to be thinking about is systemically how we are engaging with a large number of youth. So these are interesting and helpful little tidbits for thinking about how to be trauma-informed, but they aren't in and of themselves a full practice. And we have a number of people in our clinical communities who are looking for good resources around, well, what is a good trauma-specific intervention for young people? And there's a lot out there. What I always recommend is really checking evidence-based practices that we have listed on the National Registry of Evidence-Based Programs and Practices. We also have the California Evidence-Based Clearinghouse for Child Welfare, and I included the links here. Some of you may be aware of these. And then I have a couple of illustrations here of some best practices that have come up in the literature, even the literature I cited today, although there are definitely more practices as well. Trauma-focused CBT we talked a little bit about last time, so I gave you some information on that, but it's definitely a combination of helping young people soothe and self-regulate and gradually coming to a place where they're able to form a narrative about the trauma and reauthor a narrative and reauthor kind of a new way of seeing themselves in the world as part of the recovery. There's trauma assistance therapy for children and teens, also has some really excellent outcomes. And TST, again, in the brief amount of time I have here, I just wanted to let you know it's really working on two components mainly. One is assessing and addressing a youth's emotional regulation capacity, and also assessing and working with the social environment or the systems with which a young person lives. So they want to be able to find treatment plans that fit, that are phased right and developmentally appropriate for the young person, as well as helpful treatment modalities. But also really looking at where does this person live? What's their system like? Are there re-traumatizations that occur in the community or systems? And being aware of how do we manage those? Then you'll also notice I have Seeking Safety on here as well. And Seeking Safety is actually a cognitive behavioral combination approach that was developed for adults and is increasingly being tested and has some good outcomes for adolescents, although Seeking Safety can also be very useful for the adults of our youth in our system. And Seeking Safety is a program that has about 25 different modules or topics that a provider can use. It's definitely done usually in groups, although it can be done individually. But the idea is to have people look at behavioral, cognitive behavioral, interpersonal, and case management or care management issues that occur in their lives. And each topic will be addressing any one of these issues, for example, anger management or developing boundaries or symptoms of PTSD. These are all sample topics. And Seeking Safety looks at both the trauma impacts that the people in the group might have had in relation to that topic, as well as any substance use impacts as well. So it really allows for some excellent integrated substance use and mental health treatment. And it also, I find, having done Seeking Safety for quite some time, that it really helps empower the people in the program to find solutions, to make commitments to change, to use each other as resources. So these are just three strong evidence-based practices that we have people trained up throughout the state in, and there's plenty of resources around if you're interested in more. But I also encourage you to go to those links, because there's a lot out there that might have a very good evidence base that could be very specific and useful for your community. So we are going to move to our next slide. And I want to show you a little bit of this trailer from a movie that came out last year. It's actually a documentary. And it's called Paper Tigers. Some of you may have seen the entire film. It's been shown throughout the country. If you have not seen it, I really encourage you to see the whole movie because it's very inspiring. But some of these concepts about looking at what's happened to students, what happens to youth, instead of what's wrong with them, it really actually helped transform an entire school community. So we'll go ahead and
just to point out, we want to point out to the audience, this is Kim. For this particular video, we don't have closed captioning, so you're just going to see the video as is. So we're just getting it queued up right here.
Every school in America walking down every street. All of them were found out. Invited to go to a conference about complex trauma and what stress does to the brain. The behavior isn't the kid. The behavior is symptoms of what's going on in their life.
What's wrong with that? Here's Shelly. She's the only thing I have. If you're in a bad mood, stop. It's coping mechanism with treatment time, smoking time. Remember one night? I didn't want to be alive.
It hit me really hard. You have to unconditionally love them, and you have to believe that their behavior might be out of their control.
I love playing guitar. Several of these guys feel like that. It's almost as strong as anything we've ever done in class.
After that, he wasn't only a disciplined figure, he was a friend.
So you brought Pat over. Watch their confidence come back has been incredible. I'm not by myself anymore. I'm not.
If I can do it, all of you can definitely do it.
Not that I'm judging you. I know why you're smoking weed. I know why you smoke that. I know why you're right. You don't want to feel. I mean, that's the big challenge. I'm asking you to try feeling for a little bit. Because sometimes when you feel, it guides you in the direction that you should be going and not to where you are.
And you can actually find Paper Tigers. It's online, and you can also find showings of it throughout the country often. And at aces2high.org, you can also connect with the video. It's something that I would recommend, and programs have done this, getting a hold of a copy and actually showing it in their communities or showing it in their staff meetings, and it provides a wonderful opportunity for people to really think about what they did at Lincoln High School and what was really remarkable, because we talk about these concepts, and there actually are a number of schools in California that are working on becoming trauma-informed. What does it look like? What are people actually doing? So I'm going to probably reference Paper Tigers and the principle again in a minute. But just as a place to get started, I think it does a really nice job of looking at a system and having people think about, well, what happened to these kids, instead of just reacting to what are they doing. This leads us to our next slide here, where we're going to transition a bit into more specific issues that sometimes we see in child welfare, although I'd like to say that any of us working with youth in environments, whether in schools or hospitals, any type of practice or clinics, it's not uncommon to run into these issues, even with youth who are not in a child welfare environment. But this is a common, these are some common issues. It's not exhaustive because, again, we have an hour-and-a-half webinar. I know there's many more things that we could look at. But we're just kind of curious about what have been some recent issues that have come up as we're thinking about things that either are the result of trauma or that can potentially perpetuate it. And what I'd like to have you think about as you're doing this is just the importance of having individual providers, practitioners, policymakers being aware of these issues so conversations can start. I think if you think about all the stuff, it may feel very overwhelming, that there's been changes in our systems, and this is how the changes occur, by having these kinds of discussions and individual providers and family members and such doing things differently, or being curious about something, or not having an automatic response. And some of these things are more systemic. And again, the systemic things change a bit over time, but they change through conversation and concerned citizens doing something, saying something, having conversations. So that's where I'm hoping for, what I'm hoping for today is just be able to think about some of these larger issues and share some of the main concerns now, some of the progress that's being made. So I'm going to move into the next slide here. And we'll talk a little bit about the concept, the concern, the issue around over-medication. And taking our slides, that we actually have a cartoon here, and then we have this, the cartoon had this old Abraham Maslow saying, it's like, I suppose it's tempting if only till you have the hammer to treat everything as if it were a nail. And so, I'm aware that we have a number of professionals out here in the community using many, many skills working with their youth. And yet, in our communities, if you look at this slide that we have up now, the one out for adolescents in California and foster care system received psychotropic meds, we see that this prevalence of medication, which is, not to blame any one individual, there's a lot of reasons for that. There's certainly an industry out there, and there's processes in play that have increased medication among probably all young people and foster youth because of their histories of trauma, being maybe more vulnerable to this. So a lot of this information I received, I came out with various reports. The most probably widely read and regarded is a rather extensive report from San Jose Mercury News a couple of years ago. And they have a number of data points in addition to some really profound and touching and thoughtful videos from foster youth themselves. About 50% of the state's foster children of all ages were prescribed psychotropic medications. So you can see that this is, there's different rates, but it's significant in terms of the numbers. And why are we concerned about this? We're concerned about this because the medications do have side effects, including, some of the metabolic issues, obesity, lethargy, low mood, early onset, and among others. And I think for me, my own experience as well as the research is really some concerns about, are youth actually receiving the treatment benefits that are intended by various medications? A dynamic that I've observed, and you may have also have observed, and that was reported on in this particular study, was that sometimes youth are started with only a small number of meds, but often medications get added on. Medication isn't working, so there's this tendency to add another one on top of that, and then there's a side effect from that one, so there gets to be another medication. So we end up with youth with a number of meds on board. So get to the next slide here, the some youth need medication. One thing I'd like to say is I think it's important is that some youth, regardless of all this, do in fact need medication. So this is not to say that a trauma-informed approach abandons all medications. Clearly, medication is often an important tool in the toolbox, but being very kind of thoughtful about how medications are prescribed is really the important step. And also, medications can be really appealing to youth and families. So it's not as if a lot of young people or families don't necessarily want medications. For many people, they definitely want them. They find them useful. It's just really being able to find a sense of balance about that. And another thing I think, again, for us to think about, if we're thinking of trauma-informed, is what are we getting medications for? And is there a medication really designed for what we need it for? And in this article, they talk about, treating a broken heart. Can you treat a broken heart with medication? And coming back to what happened to a young person, what they might need, we might not be able to find in a bottle. It's going to be probably more through attachment or certain life experiences that may provide this slow healing. So one thing that did come from this expose, and also people's feedback around this and concerns, the Senate Bill 1174, and it's really about monitoring medications and being able to track through the Medical Board of California how are medications being prescribed to foster youth, and is it appropriate? So there has been a shift. Our governor's been very supportive of that. And I also have a link on here for the California Guidelines for Use of Psychotropic Medications with Children and Youth in Foster Care. I don't know if you've reviewed this PDF. I found it actually really quite good, really comprehensive. So I encourage you to go online and to check this out. What this guideline does, it really helps providers look at some of the expectations regarding the developmental issues and monitoring of treatment plans, or how to put them together. Also looking at principles for emotional behavioral health care, psychosocial services, and also non-pharmacological treatments. Also looks at informed consent and how to think about medication safety. So it's a really important resource, and as much as it's a concern about drugs and our young people who've had a history of trauma, it's also, I think, very hopeful to see that there's been this really very proactive state response. But change takes time, and that's why we wanted to talk about it today, just so we can all be really aware that this is in our community, and to be thinking about anyone we're working with, what does their medication profile look like? They might need medications, to be sure, and that are they being monitored, and how might we engage in that process? All right, next slide. I brought this idea of the school to prison pipeline, and I'll talk a bit about how this shows up for some of our youth. And in the next slide, I'll actually have a definition of what that means. Some of you, maybe all of you, are familiar with the definition, but I found it useful to really look at, how are we defining this? And it's really about, obviously not an actual pipeline. No one's intending to get a bunch of young people into jail, but that there can be policies and practices that unintentionally, I think that's an important piece. It's not necessarily intentional, that can move and push young people into, especially our most at-risk young people, traumatized young people, out of classrooms and into the juvenile criminal justice systems. And that's actually a definition I have there from the ACLU, and you can click on and look at that. So what's happening with the school to prison pipeline is that there's this sense of usually fear often in schools and environments, and if there's a certain amount of behavioral concern, that the idea is really again about punishment, and it ends up moving toward incarceration instead of education. But what's important here, let's go to our next slide, is thinking about what happens to people if they're not educated, and also thinking about what gets them there. So on the school to prison pipeline that I have on this slide, I actually have just some statistics I found to be pretty profound. That really most of the growth in incarceration are among young men with very low levels of education. Usually young men of color are most vulnerable and overrepresented in this population. Although young men of all ethnic cultural backgrounds, if they're uneducated, of course this could be occurring for young women as well, are more likely to end up in prison, because without educational access in our culture, it becomes increasingly challenging to stay out of institutions. We'll go to the next slide here, and the next slide I think is helpful in terms of how does this happen. Part of it is because of safety concerns that we have in the larger communities. We developed more what we call zero tolerance policies, and that youth are removed from school, and when a youth is out of school for protection purposes, right, to protect the other students, but when a school is out of school, they're also removed from a protective environment that could allow them to reform themselves, so to speak, and they're not benefiting from an education. Also because we have more school policing and the legal system is more involved in our school settings. Again, this is not to be hard on school police. Definitely they do some very important work. But it seems that when you have more of a police force presence in a school community, you might have more kind of standardized punishments that involve jail time or court cases, restitution of some sort that brings students out of the classroom. And there's also just overall, like some schools are just not, quite frankly, not functioning as well, so they are maybe very disorganized or have their other challenges, and they just can't attend to keeping students in school when there's challenges. And there's also what we call diversionary schools, where if someone has a certain behavioral concern, they might be moved into a prison, or not just a prison program, but another maybe continuation type program that may not allow them to really have access to the type of education they need to be successful. So the next slide here, so we'll look at some solutions. There's a couple of things out there that are really promising. One of them is the trauma-informed school. So I don't have this on your slide, but just I will refer you to ACES Too High, which is a website you have on your PowerPoint. So in a couple of slides, you're going to see this at the end. It's called ACES Too High. And the principal of Lincoln High School, you just saw there on the video, he tells of a story where he had a youth come to him sent by a teacher because he was flicking a cigarette lighter in class. And he's a principal, and he's like, you can't do that, right? Obviously, safety issue. So he spent some time trying to get the lighter back from the youth, and he was being, very stern and appropriate principal, like, no, this is not okay, you can't do that. And the kid becomes very agitated, loses it, starts yelling at him, lots and lots of profanity, which I will not repeat, and he leaves the campus. And so the original response, or maybe the old response, would be, okay, that's it, you're unsafe, you need to stay away from school, you're going to be expelled, maybe even detained somewhere. But the principal very consciously said, no, you need to come back to school. Now what happened is he found out from the dad, the principal did, that the child's mom had left town suddenly, and there's some abandonment piece, and he was really obviously very distressed by this. So they brought the young man back to school, and he had to spend his time in school suspension, where he eventually disclosed to a teacher there, even though he hated in-school suspension, but he came back, he disclosed to a teacher about what happened with his mom, and was able to talk about it, and was able to stay in school. So these are the types of solutions that are really important. It's what can we do to keep our young people where they need to be, which is back in school. I have on the slide, too, there's other court diversion programs. Some of you might be familiar with things like drug court or mental health courts. Sometimes there's even things like vet courts, certain types of courts for certain types of groups of people who don't need the same treatment that you would have in the adult criminal system or even the youth criminal system, but need to have some opportunity to rehabilitate, to get back on track, and really importantly, to stay in school. So these youth aren't going to youth jail. They aren't going to juvenile hall. Again, it clearly would depend on the type of crime, to be sure, but that they're kept in school and they have to check in with the judge, and they aren't getting away with anything. They have somebody who's checking up on them. There's also restorative justice programs, and I have a link there for restorative.justice.org. Really encourage you to check that out, because restorative justice is really thinking about how to bring the justice, the crime, the infraction into the larger community, and to have a larger problem-solving approach that talks about involving all the stakeholders, and that kind of transforms this relationship between communities and the governments and the people who have committed crimes, really looking at transforming their relationships and having it become more of an active problem-solving and socially responsive relationship. So, for instance, an example of a restorative justice approach might be with someone who maybe went awry of the rules. They would be sat down and asked, like, what happened? What were you thinking at the time? What have you thought about since? You know, what has been affected by what you've done? And what do you think you need to do to make things right? So that's kind of where they start. There's this engagement around helping to raise consciousness and take responsibility. And then for the people who are the victims, so to speak, of crime, it would be having questions around, well, what did you think when you realized what had happened? What impact has this incident had on you and others? And what has been the hardest thing for you? What do you think needs to happen to make things right? And that for the victims, they're actually with the perpetrator, so to speak. I'm using this language, to be able to come together and hear each other. So the decisions, the consciousness raising, the solutions aren't happening in isolation, but it's a community solution to what's occurred. And again, it doesn't cast aside the young person, but finds a way for them to be actively involved in recognizing in their behaviors and developing some alternative responses and awareness of the community. All right. So we have another piece I want to talk about before we move into our last part. And this is substance use. And again, the reason I bring up substance use is because clearly it comes up as a behavior that we see, but it's all over the place. Substance use, it's among our youth that we work with of all ages. I mean, young people who start to have a problem with substances, who will likely have problematic use, often start using as young as the age of 10 or 11. So even if we have pretty young people with us, they start young. And then their parents or the caregivers may also have substance use occurring for them as well. And we know currently, right now, with discussions around healthcare, we're becoming more aware of just how prevalent some substance use disorders are in our community. One thing to think about, and I have the ACE pyramid up there, which we talked about in our first webinar, is for many young people, as well as their families in the community, that substance use is often used as a type of coping that does obviously have poor outcomes. And here's the thing I'd like to propose is that I think for many of us working in the field, there's a tendency to say, well, I'm not a substance use professional, so I need to refer somebody out, or this just isn't part of my work here. Yet it's so important to ask and to engage and to listen to people's histories and connections with substance use. We know from some brief interaction around substance use discussions that just even having a conversation with a professional can reduce the amount that someone uses. So that's an important intervention in and of itself. You may end up linking to care, to maybe 12-step groups or to some sort of inpatient, outpatient, intensive outpatient residential treatment for someone, which is terrific, and that won't happen if we're not asking about substance use. But I'd also like to say that there's a whole lot of people out there, young people as well as adults, who probably never will go into active treatment, who might cut back, who might even just stop on their own. And how they get there and what helps speed them up in that process are thoughtful, kind, caring, curious discussions about their use. So the more they're likely to talk to somebody about it, the more often they are willing to engage in actually taking a step to cut back or to not use. And so even if you don't consider yourself a substance use treatment provider, you often are by default, because a lot of times people that we work with, they love you. They don't want to go necessarily to someone else, or they're going to really rely on us to help link folks to a different level of substance use disorder treatment. It's an important thing to think about that, like the asking and having the conversation is really important. And then I also have, and I won't spend a lot of time here, but I think it is important that with the fetal alcohol spectrum disorder, we may have young people who have histories of trauma, but then they may have all of these signs as well, or we may see these signs co-occurring with some of the other trauma history. And these, of course, are epigenetic. This is what happens as far as the basically birth defects as a result of being exposed to alcohol. And just to be thinking that this could be on board, and then you might want to do a further assessment, or again asking some questions about maternal substance use in terms of fetal alcohol spectrum disorders. But we can see certainly physically there can be issues, brain damage, also some physical organ damage, but we have all the behavioral pieces as well, potentially, like hyperactivity and attention and poor memory, and difficulty with judgment and reasoning, and learning disabilities. And the way they're classified now is really looking at these issues along a spectrum, in that some people may have more or less of these symptom presentations, depending on when, where, and how they were exposed. So finally, we're going to move into the last piece of our discussion today. And all this work around trauma, you may have been noticing, can take a toll. And even just sometimes sitting at a webinar and thinking about it can be challenging and maybe even overwhelming or triggering, quite frankly, just because it brings up some of our own history or memories we have working with individuals. So you may have heard this metaphor, and we use it a lot. You'll hear it again today, about this idea of, before you can help others, you have to put on the oxygen mask yourself. And that idea that you hear, right, you see it being talked about when you're on an airplane, like you can't help out your child until you put on your own oxygen mask. It's really a perfect metaphor for trauma-informed care as well. And it's increasingly why we're looking at provider self-care. So moving into our next piece here, we have a poll. We have another poll. We're just kind of interested in seeing, like, well, what do you do for self-care? And again, you may be doing all kinds of wonderful things for self-care, but let us know. If you don't see something on there, if you want something to add, go ahead and type it into the chat box or question box. Okay, so we have, for our results here, we all set with us? Yeah, so it's okay. So a lot of you are exercising regularly, about 25%.
And we have 12% that eat healthy most of the time, 17% get enough rest, 25% take a vacation, and 21% find ways to be mindful. And then we had others that wrote in the chat box or the question box that they pray, they go to concerts, have special events.
Excellent. Okay, great. So the importance here is that we have a number of you doing at least one thing, which is of course admirable, and be thinking about, as we kind of go through life in different times and different places, it's always great to have a self-care toolbox because there's times when you just feel like doing some things and times when you just do not feel like doing a certain thing, but it's nice to have an alternative, right? I may not want to go running tonight, but maybe seeing a movie is exactly what I need. So we're definitely looking at variety. One thing we'd like to have you think about is this concept of trauma stewardship, and some of you may recognize this. I know in California we've had some counties actually train their staff in these concepts, and to have Laura Vandernoot, who's the Vandernoot, I never say her name exactly correctly, the author of the Trauma Stewardship, come and speak to their organizations. And basically the idea, we'll show you a little clip here that Laura's put together, but just briefly, the idea of trauma stewardship is really being aware that it's not just about we treat people with trauma, but that we're all in communities where trauma is an issue and that we're all potentially exposed. And this idea of being good stewards of trauma care involves self-care, self-awareness, reflection, as well as help our clients as well. So we have kind of an fun little clip here to illustrate some of these ideas.
Here's to you, trying to make the world a better place. You take on the weight of it all, knowing there will be a cost, but never expecting to pay full for it. After a while, you notice something's giving you. You're changing. You've been there. We've all been there. The answers just aren't all that easy anymore. Now you're too drained for even the smallest demands. You're numb. You feel like you can't do enough. And you needed a nap since before the turn of the century. If you're a school teacher, a public defender, or a member of the military, so why does the world feel like a different place to you? And you're an ecologist, a doctor, a community organizer, or a caretaker to family members. It's all piling on. Some of your own choices could be starting to raise eyebrows. Let's face it, these days, when the world comes calling, you'd really rather not wake up. Your mind blown, your spirit broken, and your body is not taking any of this all that well. Something's just not how you remember, and that something could in fact be you. Hey, it's a struggle. We understand that. Doesn't mean it's too late for a change. We're here. We get it. And we have ideas for how to find a better way. Check us out. TraumaStewardship.com.
I thought that was kind of a fun introduction to this idea of self-care, and also the trauma stewardship. Of course, they have their website you can look at and find more detailed examples of what they do, but and their book as well. But that's like a little commercial piece. Sorry about that. I'll turn that off for you. Thank you. Sorry, got away from us. So one of the things we want to think about, just in this idea of dealing with our own trauma, is being able to do a bit of a self-assessment about how is it that a trauma might be impacting us. So we're going to go to the next slide, and we have here, what's the difference? Have you heard of these terms? I haven't. I have to be honest with you, I get them confused all the time myself. But it's just always useful to know, like, what's what. So burnout, you can think of it as a severe state of exhaustion or lack of energy that's usually brought on by unreasonable work expectations of yourself or from others, or environmental work-related stress. So it's often a working condition thing, and it shows up in some pretty nasty ways, sometimes in terms of behaviors and attitudes, or just being just completely fatigued, but it's about the job usually. Compassion fatigue is it's a process where we're feeling for another in a way that they begin to feel tired. So it's basically, it involves empathy, compassion, and caring, but it begins to be too much. We're overwhelmed by our own kind of experiences of this is just basically worn out from our own pain around other people's traumas. And then secondary stress, sometimes you hear secondary trauma. So what can happen is that, if we hear stories of trauma, and hear a lot of them, we can develop our own response to that trauma as well. So it's basically our reactions from vicariously experiencing our own clients' or consumers' traumas. And I got some of these particular definitions from an article by Melvin, which I attached to this PowerPoint slide. But this is really a pretty standard definitions. And can you have more than one? You certainly can. Some people have all three. Can they be prevented? I think they can. I think we almost have to think about our work as such that we have to inoculate ourselves against this job hazard, if you will. And the self-care is an important ways of doing that, as well as being able to have, some ability to advocate for self and to have discussions in a larger context about what's needed in the workplace. One thing we have, if you go to the next slide here, is just some great recommendations, in addition to the ones that we've already talked about or you had already mentioned earlier, about what to do if you really want to think about how to be really proactive about this. And early detection of burnout, secondary stress, or compassion fatigue. You can actually find, there's a lot, and there's also, of course, people who'd be willing to, show you through their products like Trauma Stewardship. There's a lot of assessment tools around that you could do or have conversations at a staff meeting around. But what's important is that we're having conversations, developing awareness, talking about what it looks like. Build a support system, and it's great to have a support system in the office, in the community, among family, friends, people who are close. Basically, if you think about your life as a series of circles around you, having people close to you in the support system, and even more further out in different locations that you can rely on, even just minimally, just for some amount of connection and empathic support. Build awareness, and one of the things I have on here is the Wellness Recovery Action Plan, call it WRAP. And some of you are very familiar with WRAP plans, but if you go to copelandcenter.com, you can actually see what a Wellness Recovery Action Plan is if you haven't heard of it. But what a WRAP plan does, it helps you be prepared for a crisis before one occurs. And so you look at what your daily rituals are to keep yourself well, and the tools that you have. You think about these, you collect these, you mindfully are putting things together. You identify triggers that may triggers to burnout or whatever it might be that you target. You look at early warning signs when you're not doing well, and you look at when things are breaking down. So what you're doing is you're identifying these places and devising action plans for managing it. For instance, when I get stressed out, one of my early warning signs is I lose my keys. So I automatically know if I'm losing my keys that I need to do more self-care. And, it sounds a little bit, I should say, kind of concocted in a way, or maybe like, how would that work? But once I found you start really thinking and being very aware of these signs and symptoms that we have, you're more likely then to be proactive if you actually have a plan. And then finally, the WRAP plan also looks at, if someone does go into a crisis, how to actually get support and to get back on track in terms of recovery. Developing resiliency skills. So, sometimes we do have to do things like practice being assertive, or like saying no, asking for what we want, learning how to stand up to people, making sure that we are being well prepared for situations that we know are challenging by making sure we eat enough and that we sleep enough. Just really being aware of like what's going to help me be strong right now, and practicing that on a daily basis. Creating time for all the great self-care ideas that you have, and I talked a little bit about assertiveness, but that we also want to be able to have a chance to debrief some of our more challenging situations with others. And I put on here, just make sure that's not your only intervention, because sometimes if we just are only being cathartic with other people or venting, so to speak, that can actually create more agitation if we're not doing other things to build up our resiliency skills and our ability for self-care. And then also spirituality and values development, this idea of if we can always have a sense of what we care about, what's meaningful to us, then that can be our compass. When things get dark or things get challenging, we can always look at what am I doing today that helps me move towards this goal in my life or this value in my life that I think is really important. If my value is my family and that's the most important thing, and I really want to develop that, how is working 18 hours a day, how's that helping me have the family life I want? And then just really think about, well, how might I get more balance, for instance? And I've created some of these what to do steps for some of my own in addition to what Melvin came up with. But I did, again, reference the Melvin article if that's something you might be interested in exploring in more depth. And then we actually have a really nice TED Talk that summarizes, I think, in a helpful narrative way, exactly what we're talking about here that we're going to show you 12 or so minutes, and then we'll finish up after this and entertain some questions. So hold tight for TED.
Let's play a little game. We'll play a word association game. I'll say a word and you can picture something in your head. You can even shout it out loud. Are you ready? Cow. Okay, so most of you maybe were thinking this. Maybe a few of you were thinking more this. And maybe some of you thought this. We'll do another one. Work. Awesome. So some of you really love your work, like this. Maybe a few of you were thinking this. And I wonder if anyone felt this. We'll do just one more. PTSD, or post-traumatic stress disorder. So most of you thought this. Maybe a few of you were thinking this. But I wonder if anyone thought this. Compassion fatigue is the post-traumatic stress disorder-related symptom that you receive vicariously as a secondary target to trauma. Compassion fatigue is experienced by those in a healthy profession. Doctors, nurses, counselors, therapists, police officers, and maybe even you. If your unpaid role is that of a healthy professional, then you may also be affected by compassion fatigue. If you are the middle of the night phone answerer or helping a friend through addiction or anxiety, if you are raising children or caring for parents or maybe both at the same time, if your unpaid role is that of a healthy profession, compassion fatigue could be affecting you as well. Now, what puts you at a greater risk for compassion fatigue is empathy. Those generally in a helping profession have a very strong empathetic response. And empathy is that ability to pick yourself up and put yourself in someone else's shoes and get it, really get where they're coming from. The problem with empathy is you don't get to decide when to jump out. And the traumas they experience begin to change you. I remember when I was the supervisor of a therapeutic group home, and I was sitting down with one of my clients. She began to tell me the horrific and painful stories of her past. And as she laid out in detail what she had experienced, my cell phone began to vibrate. And I wanted to show her that I was listening and I cared about every word she said, so I picked it up and I silenced it and I put it back down and I continued to listen. From that day forward, every single time I picked up my cell phone, swiped to silence it, I was transported back to her trauma. My brain had created a PTSD-related symptom that transported me back to her situation every single time for years.
Now, this would be pretty normal if it happened that day after work at the grocery store, or maybe even a week, 2 weeks later. But where we get concerned that maybe this trauma is starting to change you is when it's sticking around for 4 weeks, 6 weeks, and maybe even longer. Now, for many years, compassion fatigue was confused. People called everything burnout until Dr. Charles Stigley came around in the late 80s and 90s and began to do research. We called it burnout, but the truth is there's a significant difference between burnout and compassion fatigue. Burnout has to do with being worn out, tired, and just flat out not liking your job. Compassion fatigue has to do with being afraid. Compassion fatigue begins to change your hardwiring, change who you are. We see this a lot in child protective service workers. They start to become overly vigilant, believing that everyone is out to hurt them and their families. When I think of this, I can't help but think of the nurse who came after one of my classes and said, still to this day, she can see the broken bones of the young man who was abused by his parents. That still today, she knows the smell of death from a patient who laid in bed dying. These memories, they do not just go away, and they begin to change you. But we like to make excuses because we think we're superhuman. So we say things like, I'm fine. I'm a professional. I can deal with the stress. In fact, it doesn't even stress me out. My famous talk off was, I've been doing this for 15 years. I know most people think it's stressful, but I'm okay. The problem with that is when stress and trauma start to affect you, your brain and your body, they do not pull for your opinion. And they will start to show signs and symptoms because your body and your brain are shouting at you, I am not okay. I cannot handle the trauma. In little ways, whether you start to have sleep problems, either you're sleeping all the time or not able to sleep at all. Another way it manifests is becoming a workaholic. I know plenty of you in this room thinking there's nothing wrong with being a workaholic. Get off my toes. Let me tell you why it may be a problem. Because when we start to feel like we are losing control of the world around us, what we do is we roll up our sleeves and we work a little harder. And I can work hard enough to make this trauma go away. Another sign and symptom is feeling unappreciated and under-resourced, like what you have is not enough to get the job done. Now, I'm not saying that's not true. There's a very good chance you are indeed underappreciated. But when you started in this helping profession, or when you started helping your friend or your family member, did you know you were going to be underappreciated, that you said, it's okay, I want to do this anyway. It's okay, I love you enough. But then somewhere along the way, that is no longer okay with me. It is no longer okay that I am not safe and that I don't have what I need to succeed. What that tells me is your circumstances, they didn't change. You did. Maybe you changed because of life. Maybe you changed because of maturity. But maybe you changed because of compassion. The last symptom I want to talk with you about today is called self-entitlement. And self-entitlement is a justification of negative maladaptive behaviors because of the positive things you do. The best way I can picture putting this is most of us went to school and got a degree or a certification to be professionals at what we do. But the truth is, I'll let you in on a secret, it's not enough for overachievers. So we require little invisible badges to really be professional. Let me tell you what these invisible badges look like. For social workers, I know it looks like this. I stayed up all night long helping Joe Smith at the hospital. Now I'm a real social worker. For some healthcare professionals, I know it looks like this. I worked 2 shifts in a row. Now I'm a real healthcare professional. Where this turns into self-entitlement is when it looks like this. stayed up all night helping Joe Smith at the hospital. That's why I'm a little cranky today. I'm biting everyone's heads off. I worked 2 shifts in a row. In fact, I worked 60 hours this week, so I'm getting wasted all weekend. We begin to justify the negative behavior because of positive things that we do. Now that I have thoroughly depressed you, I want to give you some good news. That compassion fatigue can be identified, arrested, and treated at any time. That you can begin this journey for post-traumatic growth. That you can be better after trauma than you ever were before. And the best way I can think of putting this is when you think of an airplane, you know that the stewardess tells you where those exits are, and then they begin to tell you to please put your mask on you first before assisting other people. Now, every time I travel for vacations with my family, I show the stewardess that I'm listening. I get the cue card out of the backseat pocket, and I give eye contact. I'm almost the only person on the plane listening. And I show if the plane went down, I could save the plane. I'm real intense about it. And yet it never fails. Every time they finish, they come over to me, and they say, excuse me, if there were a change in cabin pressure, what would you do? And I'm a little offended. I don't know why they asked me that. But you see, that flight attendant, they see something you don't. They see the carry-ons that I travel with. They see this. They do see me. And they see this. You see, that flight attendant knows that no matter how much I listen to them, that I will put their mask on them before caring for myself. And you see, she also knows that no matter how much of a supermom I believe I am, that I cannot live without oxygen. And yet every single day we do the same thing. I put your mask on you, and your mask on you, your mask on you. And I don't care for myself. But you see, we can only give what we have. We give out of who we are. And if I don't care for myself, I certainly cannot care for you. So I'm going to ask you to complete a piece of homework for me. And I'm going to ask that you please do this every single day for the rest of your life. I have big expectations. I'm going to ask that you take 10 minutes just for you. 10 minutes to put your mask on you first. 10 minutes to pray or meditate, to exercise or take a walk. But 10 minutes to care for you first. Take 10.
All right. Okay, so hope you were able to enjoy that. I think she brings a lot of really helpful ideas and thoughts and just concerns, I think, that are really specific to our field. And she also does me one better by actually having an oxygen mask as a prop, which I think it even kind of brings it up another level. But that idea, again, of even just doing the 10 minutes a day, just even the smallest piece as some aspect of health hygiene is really a very useful idea. And just the awareness, the willingness, having that toolbox, building a toolbox, and coming up maybe with your own, wellness plan. Probably a wonderful next step. So we're going to move to our next slides here, and I think we are pretty much at the end. We just really have about 7 minutes left. We want to take at least one question or so. I have a couple of article references. There's articles in here that I referenced that I wanted to make sure you knew where to find them if you want to look for them. Additionally, I have on here also some of the websites. There are also websites embedded on each of the slides. So there's plenty to explore in this PowerPoint if you want just to kind of go through and look at all the different pieces and resources. that are out there. There's a lot. And now I think we will take a question or two and
Great. Thanks, Kristen. Really interesting webinar. So we've got a couple of questions. Kelly's going to read the question, and then Kristen will answer it.
So here's our first question. What is your experience with therapeutic behavior services coaching, TBS coaching?
well, I'm not sure if it's my own personal experience or just what I think about it. I think I will say this. The idea of addressing behaviors and coaching, I think, is useful for a whole variety of presentations and people. And the only thing I would think about that maybe is possibly part of what you're getting at is to have a trauma-informed approach as we engage in those types of services, and to be curious about various behavioral interventions or coaching. What kind of behavior are we changing, and thinking again, what's the function of that behavior, and being able to potentially have a broader conversation or consideration as to what it is the young person is trying to achieve by the behavior they're doing, and be able to think about different ways of shifting either their motivation or helping them try out, a whole variety of alternative behaviors, understanding that that's kind of what it's about. It's about really looking at the function of the behavior as opposed to a particularly difficult behavior that has to be extinguished. I mean, that potentially is true, right? It might be a behavior that's not going to be helpful, not good for them, not good for the community. But I think by having that, what happened to this person's approach, what are they trying to do by this behavior, helps put us in a more open and flexible place about seeking behavioral solutions that might be better taken in by both the young person and their families.
Kristen, we have one more question. How to treat a person with trauma that may be affected or controlled by medication and getting a successful result?
Okay. So I think part of this question is this idea if someone's on medication, is medication potentially masking symptoms, and or is the medication creating some side effects that might also be challenging to actually reach or connect with someone. So my thing is thinking about medication as part of a treatment plan and program, and to be having conversations with the person who's prescribing and becoming really clear about what some of the potential interactions might be. One of the things I consider, and I consider this with the adults I'm working with as well as with young people, is that if someone has medications that are working out more or less good enough, it may not be perfect, but as we think about sometimes it's good enough parenting, I think we can also think of good enough medications. That one of the aspects of good enough is that the person is stabilized enough to be able to really engage, to have conversations with me, to try out new behaviors. So I'm thinking of medications as being a potential link to actually being able to do some really effective behavioral and effective kinds of work with someone. And clearly, if it seems like, these medications are on board, they're dampened down, they're not connecting, or it's making things worse, the issue there is having honest and open and continual conversation with the prescriber. So if a medication's in the way, that isn't right. That isn't what should be happening. Now, granted, I know sometimes we have to deal with behavioral issues before someone gets their meds perfect, but to be having that as a goal and as an aspiration, I think is important.
Okay, well, that's it for the questions, and we are just about out of time.
Great. So I want to thank Kristen for a really interesting presentation. I want to thank everyone in the audience for asking some interesting questions. I want to point out one more thing is that we do have this link on our CCR webpage on the CIBHS website with all of these webinars. So there'll be the 3 webinars that Kristen did about trauma-informed care. There's also 2 additional webinars related to understanding the child welfare system for the behavioral health system. One is a general overview, and then one has a specific focus for small counties. So with that, we are done. Thank you so much. And if you have any questions or comments, you can send an email to ccr@cibhs.org. Thank you very much.